Hi, I'm Stephen Russell. Today I'd like to show you the physical exam that can be used when a patient presents with shortness of breath or dyspnea to help determine if the symptoms are due to congestive heart failure with low ejection fraction. This is a summary of the 10-minute moment for heart failure. The 10-minute moments from the Society of Bedside Medicine help assess the physical examination skills of trainees. Each 10-minute moment contains two parts: faculty development section and an assessment section. When a patient presents with dyspnea, certain physical exam findings increase the likelihood that these symptoms are due to heart failure with reduced ejection fraction. Keep in mind, the 10-minute moment is a tool used to assess physical exam skills alone. It's not designed to assess learners' history-taking skills. As with all clinical encounters, the examiner should have a pre-test probability of what the diagnosis might be and then use data, in this case data from the physical exam, to increase or decrease the pretest probability of disease. This concept is known as the hypothesis-driven physical exam. Before performing a cardiac exam for the chief complaint of dyspnea, the examiner should have a sense of how the exam will help determine diagnosis and management. As an overview, physical exam signs of congestive heart failure or elevated filling pressure of the left ventricle include abnormal vital signs, abnormal neck vein inspection, abnormal abdominal jugular test, abnormal palpation, and abnormal auscultation with the presence of a third heart sound, and potentially abnormal lung and pulse examinations. When it comes to the clinical question at hand, does this patient with dyspnea have heart failure due to low ejection fraction? The presence or absence of crackles is not predictive of heart failure as the cause. Note that peripheral edema is also associated with heart failure with reduced ejection fraction, but when found on an exam before a diagnosis is made, peripheral edema is not a physical exam predictor of whether the etiology of dyspnea is due to heart failure specifically. Many conditions can cause peripheral edema. For more information about the techniques demonstrated in this video and the interpretation of the findings, visit bedsidemedicine.org. After cleaning your hands, the first step of this cardiac exam is to observe the patient. The most effective observation occurs directly over the area of interest, in this case the precordium and the posterior lung fields. To effectively do this, have the patient change into a gown. Observe if the patient is comfortably breathing or if the patient has an abnormal respiratory pattern. Notice if the patient has difficulty getting onto the exam table or repositioning in bed. Next, check or review the vital signs. The heart rate can be assessed at this point in the examination by examining the peripheral pulses. A heart rate of greater than 100 beats per minute in a patient with dyspnea indicates elevated left ventricular filling pressure. Also, observe the respiratory pattern and the respiratory rate when inspecting the patient. The finding of periodic breathing in a patient, alternating between deep inspiration of hyperpnea and the absent inspiration of apnea, is known as Cheyne-Stokes breathing. This predicts the presence of low ejection fraction. Next, examine the neck veins. Elevated venous pressure in patients with dyspnea indicates cardiopulmonary disease. Normal venous pressure in patients with dyspnea indicates liver or kidney disease. Start by adjusting the head of the bed. I'll have you lift your head up for just a moment. Thank you. This is best done in a well-lit room. While either side of the patient can be used to assess the neck veins, most are familiar with examining from the right side. Keep in mind, the height of the venous column changes with respirations. The venous column also decreases as the head of the bed is elevated. The venous column can increase with pressure on the abdomen. If the height of the venous column remains elevated after sustained abdominal pressure, this is indication of increased central venous pressure. The abdominojugular test can help determine if a patient has elevated central venous pressure. Perform the abdominal jugular test by holding pressure on the middle of the abdomen. I'm just going to put my hand right here. Make sure an appropriate amount of time is given when applying pressure. A positive abdominojugular test is when the venous column rises more than 4 centimeters during abdominal pressure. This exam finding indicates increased filling pressure of the left side of the heart. In patients with normal central venous pressure, this maneuver may elevate the venous column for only a few seconds or may not elevate the venous column at all. The next step in evaluating a patient with dyspnea is palpation and auscultation. With the patient still supine, palpate the precordium. I'm just going to feel right here. Feel for the apical impulse and report its location relative to the midclavicular line at the fifth intercostal space. A displaced apical impulse, felt when the impulse is lateral to the midclavicular line, about here, is a reliable physical exam sign of an enlarged heart and reduced ejection fraction. Next is cardiac auscultation. When a systemic approach is used for auscultation, the patient is much more likely to get a thorough exam. First, start by covering the patient to make sure that she remains appropriately covered and modest. I'm just going to be lifting up here, if that's okay. Thank you. What we like to do is examine in a systemic pattern, so starting from the right upper to the left upper, and then down to the left lower sternal border. I'm just going to listen right here. And finally to the apex. Examiners are much more likely to appreciate subtle heart sounds and changes when they go in a systemic fashion. Make sure to listen medially to the cardiac apex. If the heart sounds remain difficult to hear, have the patient turn to the left lateral decubitus position and listen again. The third heart sound, the S3, occurs early in diastole. Its presence indicates rapid ventricular filling during diastole. When present, the S3 signifies increased filling pressures, dilated ventricles, and systolic dysfunction. Since it's low-pitched, it is best heard when placing the bell over the apex. The intensity of the sound will diminish with inspiration. I'm going to listen one more time. Thank you. One way to remember the sound and cadence of the S3 is to say the word Kentucky. Of those 3 syllables, the final one represents the S3 sound. Note that the S3 will begin to disappear with effective diuresis, so the initial presence of an S3, followed by its absence on serial examination, is a bedside indicator of a patient responding to therapy. The final aspect of the exam of a patient with dyspnea is to perform a lung examination. As with lung examinations for any chief complaint, the examiner should note the respiratory rate and the respiratory effort, and then examine both anteriorly and posteriorly with the stethoscope applied directly to the chest wall, not over the gowns or clothes. Can I have you sit up for me, please? Thank you. Keep you covered here, and if you could swing your legs off to the side there. Examiners should specifically auscultate the lung bases. If crackles are present, have the patient cough and re-examine, checking to see if the crackles persist, indicating the presence of alveolar fluid or parenchymal disease causing the crackles. If the crackles resolve, this indicates improved large airway secretions or resolving atelectasis. The physical exam of a patient with dyspnea ends with examination of the peripheral pulses. Make sure to note capillary refill and the relative temperature of the extremities, warm or cool, as an indicator of perfusion. I'm just going to feel right here on your radial pulse. I'm going to feel the back of both hands. And I'm going to do the same thing with your feet, just checking on the pulses down below. When it comes to the clinical question at hand, does this patient with dyspnea have heart failure due to a low ejection fraction? The presence or absence of crackles is not predictive of heart failure as the cause. Note that peripheral edema is also associated with heart failure with reduced ejection fraction, but when found on exam before a diagnosis is made, peripheral edema is not a physical exam predictor of whether the etiology of dyspnea is due to heart failure specifically. Many conditions can cause peripheral edema. Finishing up with the 10-minute moment to assess dyspnea, the learner should confirm the patient's comfort, privacy, and well-being during the examination.